Hello everyone. Thank you for attending the webinar, and soon we will be starting our webinar about surgical retina, and I would like to thank Novartis as well, Emirate Ophthalmic Society, for organizing this session. And as always, I would like to remind all the attendees to write their answers, questions in the question box. I would like to remind all the attendees to write their question in the question column there, so we will be able to attend all of their questions at the end of the session. Unfortunately, there is a minor changes in the order of the presentation. Dr. Barbara, she will join us later and she will present her presentation maybe as a second or third speaker according to her availability. So again, I would like to thank you all for attending this session, and I would like to remind all the attendees to write their questions in the question box provided in the platform. So for the next 1 hour, we will be discussing different huge topic in surgical retina, and we will start with Dr. Flavio Rezendi. He's a professor of ophthalmology in University of Montreal, Montreal, Canada, and he will share with us his expertise in transconjunctival choroidal detachment. Hello, Dr. Barbara. Welcome.
Sorry for my delay. Hello.
No, it's okay. So we'll start with Dr. Rezendi, then it will be your session, okay?
Thank you so much.
Thank you. It's okay. Take your time.
Hello, Hussein.
Hello, Dr. Barbara. So Dr. Rezendi, he will present for us for the next 15 minutes his transconjunctival choroidal detachment drainage and his tips and tricks. And Dr. Rezendi, the floor is yours.
Very much, Nora. Share a screen here. It's truly a pleasure to participate in this session. Think very highly of Barbara, and Nora was my fellow a couple of years ago, so this is a very Saturday afternoon here for me. So the topic that Nora asked us to discuss, it's transconjunctival choroidal detachment drainage. I have no financial disclosures. So we have two entities, being the serous choroidal detachment and the hemorrhagic choroidal detachment, and they can both be approached with transconjunctival choroidal detachment drainage, with some differences between each situation. So this was a part of a film that we received an award for ASRS back in 2010. And we all know that most choroidal detachments don't need any surgical drainage. Just medical management is sufficient. It's fairly common after trabeculectomy and even more after the tube shunts. And the primary surgical indications would be severe anterior chamber shallowing, vitreous or retinal incarcerations, and especially when you have explosive choroidal detachment during surgery. Persistent decreased visual acuity, most frequently due to hypotony maculopathy, prolonged or appositional choroidal detachment, in some situations extreme pain very soon after, especially glaucoma surgery. So the conventional technique, as we all know, we have to open a lot of the conjunctiva, loop the muscles, and do a scleral cut down to drain. Some situations, especially for glaucoma patients, you don't want to, have to open that much of the conjunctiva. In some situations, the patient have anticoagulation treatment. This may be a very messy procedure. So here, so what we designed years ago is we put the infusion line in the EAC. You put a choker about 7 to 8 millimeters from the limbus, and the BSS being injected an EAC will push the choroid and drain the fluid, either serous or hemorrhagic. So a couple of years later, we published the surgical technique, and we highlighted the importance. This was back in Retina in 2012, and we highlighted the importance of placing the infusion line in the AC rather than trying to place it in the pars plana, which some surgeons prefer. The reason for that is that you may have your infusion in the vitreous cavity, but depending on the size of the choroidal detachment and the location where you go in, you may pierce through the choroid. You may be piercing through the retina, so it's a very dangerous placement of the choker for the infusion line in the vitreous cavity in large choroidal detachment. So I highly recommend we place the infusion line in EAC. This was actually our first case, was back in 2004, as you can see here. So the very nice part of this technique, it's actually that you don't necessarily need a vitrectomy for it. So if it's a simple or let's say if it's only a choroidal detachment present, here it's a case of serous choroidal detachment. All you need to do is place the infusion line in EAC, pump the pressure to around 60 millimeters of mercury, and you place the choker 7 to 8 millimeters from the limbus, and the fluid drains through the cannules. So this was back 2004. So the cannulas today is slightly different than these. And so here you see that there was a partial drainage of the choroidal detachment. So here was drained, but all around was still present. Most of the time, all you want is to open up the macula. So you don't necessarily need to drain it all. Although here was my first case, so then I decided to do a second drainage side, and you can see that with the second drainage, everything was drained. So again, this was only a choker placed in the vitreous cavity only for the light pipe, just for us to understand what was going on, but no vitrectomy was performed. This was our first case way back then. So I had a lot of resistance to this technique because of, oh my God, this is so dangerous, putting a choker in a suprachoroidal space. This is crazy. So then, in this particular case, we placed a 23 gauge choker. So this is more recent surgery. As you can see here, it's a one plane incision. No, there's no two planes. So I put the endoscope in the suprachoroidal space, and you can see here the free floating ciliary nerve. But all the blood vessels, they detach with the choroid, except at the insertion of the vortex vein. So you see that you have enough space, and then this was a valve choker just so the fluid wouldn't drain before I did the endoscopy. So I usually prefer to do a non-valve, place a non-valve cannula for the choroidal drainage. So here was a case that was combined with vitreous hemorrhage. So during the vitrectomy, the choroidal may reaccumulate, and that's why, if it's possible, I prefer to delay the vitrectomy. You do only the choroidal detachment drainage at first, but here we opted to do the vitrectomy, remove the vitreous hemorrhage, and then I did a second drainage through the same cannula, and then there was a complete choroidal reattachment. No air fluid exchange. Keep this one in mind. No air fluid exchange. So here, another case, again, of serous choroidal detachment. So draining through the cannula, you can see here there was a partial drainage. So just comparing a pre-drainage, see how much. So this patient was drained because of hypotony maculopathy. So this is pre-drainage, and then post-drainage, you see the difference. But there was still some choroidal left, choroidal detachment left. And then another alternative, when you are performing vitrectomy, it's actually You see here, there's still a fairly large choroidal detachment temporally. You can actually still keep the cannula in the suprachoroidal space and use the PFC, which is a different technique that has already been described, by the way, by an Italian group. And so then you can, increase the drainage if you deem as appropriate. And this is specifically important if you have associated retinal detachment. So here, another case here, it was due to a flat anterior chamber. So you see here, I had a tough time to place the infusion in the AC. And then you see the small pupil, flat chamber. And as soon as we are able to drain the, place the trocar in a suprachoroidal space, again, one plane, there's no angulation. You can see how the pupil enlarges and the chamber deepens right away. And this is a good example that you can see that there's a lot of, that you're first in a good place, and second, that you see that the chamber deepens. So the large part of the choroid that was pushing the iris forward, it was released. And so here was a combination of vitreous hemorrhage, choroidal detachment, and a retinal detachment. So we went ahead and removed the vitreous hemorrhage, placed the PFC, removed the PVR, which is not the case here. And in this particular situation, I kept the cannula in the suprachoroidal space, and I went ahead and then did air fluid exchange. I don't really like this because you may have, as you're doing air fluid exchange, the choroidal detachment can reaccumulate and actually push the choroidal detachment posteriorly, and it may even reach the macula. So if you are comfortable doing PFC oil exchange in case of combined retinal detachment and choroidal detachment, I recommend this. It's not a procedure that I do very often, the PFC oil exchange, but in this particular situation where you have RD and choroidal detachment, it may be a place for this technique. So this was a patient who had multiple factors for PVR, including a retinal detachment or detachment post-trauma. So then we did everything preventively in this case. So we did a combined phaco, which that you don't particularly want to do usually when you have a choroidal detachment to do a phaco. But with this particular technique, we may allow it to do so. So we put the infusion line in the AC, drain the choroidal detachment, see that drain completely. You perform the phaco the whole time with an infusion line, with a secondary infusion line. Even when you have the phaco, you still have a second infusion in the whole time to avoid reaccumulation of the choroidal detachment. In these high-risk PVR patients, I prefer to put a 3-piece IOL in the bag in case there's anterior proliferation later on that I have to remove the capsular bag. As the worst-case scenario, I can still use the same IOL to put a fixate in the sclera as a flange technique, the Yamani technique. So, and then we went ahead and did the whole approach to the RD, and at the end of the procedure, we're doing PFC oil exchange. So this is my preferred technique these days to approach a combined regmentogenous RD and choroidal detachment, and I highly recommend you suture all the sclerotomies in cases of combined RD and choroidal detachment to avoid the reaccumulation. So this was all cases of serious choroidal detachment and associated with different entities, passing to the hemorrhagic choroidal detachment, which is a much more complex scenario, usually post-trauma, sometimes post-glaucoma surgery, or cornea surgery. So here you see with intraoperative OCT, you see the angle totally closed. See, this has total hyphema with a kissing choroidal, a hemorrhagic choroidal. This is post-traumatic. So then placing the infusion in EAC. So when one of the difference between serous and choroidal and hemorrhagic choroidal, I use a 23 gauge versus a 25 gauge. So 25 to drain serous, 23 to drain hemorrhagic choroidal. So here, placing 7 to 8 millimeters from the limbus after we drain the hyphema, and then you can see the blood being drained through the 23 gauge choker. Then we place so just the light pipe again. No vitrectomy done here. And it was a pretty severe hemorrhagic choroidal. So with the intraoperative CT showing that the macula was freed from the hemorrhagic choroidal. So that's all you want in these situations, to free up the macula. The rest will resolve post-op and medically treated. And you can see at the end the angle being totally open by the drainage. So it's a nice use of the intraoperative CT, helping us to approach these kind of cases. So this was a patient who presented, again, trauma with an extreme ocular pain secondary to a hemorrhagic kissing choroidal. So here you see pre-drainage. So in this particular case, it was an early on. So I usually wait about 2 weeks to drain a hemorrhagic choroidal, but this patient was in extreme pain. So we inject TPA on a suprachoroidal space, put the patient in the room, inject in the suprachoroidal space the TPA, wheel the patient out, did another case, and then we wheeled the patient in, and then we went ahead and did the choroidal detachment drainage. So in these early cases, most of the time, even with the TPA, it doesn't drain very much. So what we did here is you can actually place your vitrector through the cannula into the suprachoroidal space and make sure that the port is facing the sclera, and then so then you can do a vitrectomy in the suprachoroidal space to get rid of the thick blood clot. Again, this is only in an extreme situation that you have to approach the kissing choroidal early on in a hemorrhagic, not serous. Okay, so then here I'm in the suprachoroidal space, and then as you can see here, this was combined with vitrectomy. It was a much more extreme situation, and you can see slowly drainage. Again, you just want to open up the macula. You don't necessarily need to drain too much, especially with a vitrector in the suprachoroidal space. So you just only want to open up. And in fact, after you start doing vitrectomy, you may actually start liquefying the surroundings, and it help further drainage. And this was PFC added as well. So this is pre-drainage, and then post, like you see, opening all the macular area. So difficulties and mistakes. So here was a case that we had already drained, where PFC guided, and then we removed the choker from the suprachoroidal space and did air fluid exchange. So as we're doing the air fluid exchange, you can see here a pretty large choroidal detachment reaccumulating and being pushed posteriorly in both sides, the temporal and nasal. So not to do it if you can avoid. Another difficult situation here in some hemorrhagic. So this was post extra cataract surgery. It's rare and rare, but still happens sometimes. These techniques in some countries. So here, we placed the 23 gauge choker in suprachoroidal space. Hemorrhagic is actually explosive hemorrhagic. So nothing was coming out. So, sometimes you can manipulate the cannula in the suprachoroidal space, but it still wasn't coming out anything. So you can actually use a sclera depressor or a Q-tip. So, pushing some, so it's bleeding from the conch, but it's nothing really draining. A little bit here. So sometimes in a hemorrhagic choroid detachment, you actually have pockets and some blood clots. So sometimes the blood clot may be plugging the cannula, and so using a Q-tip or sclera depression, you can actually try to squeeze it out through the cannula, and you can see here in a second that it started draining, and then all of a sudden you're going to see a little pop there. So through the blood clot went through, and then everything drained. So don't give up if if you think you're in the right position. Here, a combined situation, a super hard drop nucleus in the presence of choroidal detachment. So you have to really be careful. Try. So here we have to, you couldn't eat with the vitractor. You have to put the fragmentome. The fragmentome, you have fluid leaking through the edges of the fragmentome. You have to do like a 19 gauge, 20 gauge sclerotomy. So that's a tough situation that, you can avoid. It's better, but, try to keep everything in control during this lensectomy. Here, if you don't listen to Dr. Resende and you still want to put the choker in the infusion line in the vitreous cavity, you have to make sure that you put the infusion, then you put another sclerotomy to put the light pipe and make sure, or go with the indirect and make sure that you see the cannula in the vitreous cavity before opening the infusion line to make sure that you don't make things even worse. Here, so when you have a choroidal detachment, to place the sclerotomy in the suprachoroidal space, it's rather challenging because it feels like when the choroid is attached, you actually have a counterforce on the sclera to allow you to penetrate. But when the choroid is detached, it's kind of like the choroid, the sclera goes with your choker. So that's one reason why I prefer when you start this technique that you go with 25 gauge versus 23 gauge because it's easier to put. So you can see here, although I'm having difficulties, I'm never changing the plane of entrance, always on the same plane, because you're going to see something a bit later that it's scary. Should not do. Even though you're still having difficulty, keep going until the entire cannula is inside the sclera. Okay? If you're too shallow, you're going to be intrascleral. You won't have a drainage. And then if you're too perpendicular, then you have a big danger of hitting either the retina or the choroid, which is not recommended. So here you see what not to do. So then it was a 23 gauge. Instead of keeping the plane, he actually went entirely perpendicular. Please, this is a do not do situation. You can actually have big bleed. And in fact, it didn't drain at all. So it may have been plugged by the choroid itself. Another thing to watch for is that as you're placing your choker, make sure that your infusion doesn't pop out of the AC. So you want to tight this AC paracentesis to keep the infusion line in position. And last case here, the same eye actually again wasn't able to go one plane, and then he changed plane and they went in straight perpendicular. So and with no drainage again. So you do not want to do this. You want to stay safe in the suprachoroidal space. Do not go perpendicular to avoid hitting important structures. And I'm open for questions at the end of the session. Thank you very much.
Thank you very much, Dr. Resende, for this great videos and great, very challenging cases. So many questions for you, and we'll like to share our question at the end of the webinar, if you don't mind, and if you don't mind to stay with us until the end, Dr. Rosalie.
Sure.
So next we will, it's my pleasure to have Dr. Barbara with us, and she's from Italy, and she's one, I have never met her in person, but I would love to meet her. She's a very pleasant, kind person, and she's a vitreoretinal surgeon as well, with the great expertise in macular surgery. Today she will present with us, she will present for us myopic macular retraction and different techniques to treat, and as well to triage those cases. The floor is yours, Dr. Barbara.
Thank you. I'm sharing the talk. All right. You just stop me if it doesn't look good. So myopic traction maculopathy, I will present you a new staging system and the guidelines of management. This is one of the last paper that came out on vitrectomy, and as you can see, vitrectomy as a standalone treatment for MTM does not show very encouraging results. You can read functional success achieved in 60% and anatomical success in 80%. I think we should not stop at these results. I'm not saying it's false, these are true, but many colleagues seem to give up on myopic eyes, and the good news is instead that this eye can see if we apply the correct management that has to be customized per stage. So let's focus first on what is the pathogenesis of MTM that I summarize in the game of forces on the fovea. Let's see what I mean. So if this is the eye wall, vitreous and retina, in the normal situation without MTM, when everything looks good, there is a centripetal force that points to the fovea. So the fovea is held together, and probably in this force, a key role is played by the Macular cell, the external limiting membrane, the internal limiting membrane, and the retina in the retina structure. So against this unique centripetal force, we have a series of centrifugal force that act in MTM. The forces perpendicular to the retina induce schisis and detachment, and the forces tangential to the retina induce foveal splitting. So let's say if we have a centrifugal force exerted from the posterior eye wall, the posterior sclera, we have an elongation of the eye, and in the end we might have a sclera detachment from the retina, not the opposite. I don't like to say retinal detachment, but scleral detachment, because this is what it is. The sclera can also enlarge, and we can have a centrifugal force from the lateral eye wall, enlarging the eye and detaching the sclera from the retina because of enlargement. But we can also have centrifugal forces from the vitreous, which are pulling anteriorly and detaching the retina anteriorly on the vitreous side. Also, we can have centrifugal force at the interface, again exerted by the vitreous, but tangentially to the fovea, and in that case, we will have holes. The forces can be combined, centrifugal and perpendicular force, and centrifugal, perpendicular, and tangential forces, resulting in retinal detachment associated with macular hole. So if you study, as I have studied, the natural history of MTM, and you look what happened to these eyes if we do not treat them, we can see that MTM is divided not in type, but in stages. It is an evolving disease. So I would like to present you the Mtm Staging System that I have published recently, and which is summarized in one single table. So look at this table, because in this table you have everything you need to know on MTM. Let's start in stage 1. Stage 1 means that we have an initial schisis in the inner or outer layer or associated. And if we have a perpendicular evolution perpendicular to the retina, it will evolve in stage 2 with schisis in deeper layer. And then it will evolve inevitably in stage 3. In stage 3, you can see that the fovea has a detachment. And in stage 4, the whole macula detaches from the sclera. And please observe that while the retina detaches, the schisis inside the retina resolve, because basically the retina detaches completely, and so the inner forces inside the retina are released, and you do not observe schisis anymore, only detachment. For each stage in the retina, we can have different stages in the fovea. So this is A. In all the columns, you can have stage A, which means normal foveal profile. In every stage, the fovea is intact, the inner fovea is intact. But if we have tangential forces pulling on the fovea, it might evolve in stage B, which means inner lamellar splitting, inner lamellar hole. And if the force tangential to the retina evolves, it will become a full thickness macular hole. And this is true, as you can see, for each stage. I have added for each single stage the average visual acuity that you can have. I have studied so many eyes, hundreds of eyes, and that is why I have pulled together the average visual acuity that you can find per stage. And also I have added in blue the time taken, actually the mean time taken to evolve from one stage to the next. And this is very important because well, this is to show all the different situation, just to tell you that it can evolve from top to bottom, from left to right, but also in oblique. And as I was saying, this table will serve to offer the correct definition of each stage, but also information on prognosis and, in the end, treatment. Prognosis, because if you have now in your office a stage 1A or a stage 2A, you know that it will evolve slowly. Visual acuity is fairly good, so you can tell them, let's see each other in 1 year, 1 year and a half. If you have a stage 2B, you might consider to do something based on vision. But if you have stage 3, stage 4, or even worse with the macular hole, then you have to tell this patient, let's do something now. But what? In summary, remember this: if you have a retinal pattern, a retinal anomaly like schisis and detachment, these will be solved by a macular buckle, because perpendicular traction should be pushed by the buckle. Instead, if you have a foveal problem like holes, you will have to do a vitrectomy and close the hole with ILM flap or whatever technique you want to use. Again, it is the game of forces. So if you have a forces pulling the sclera from the retina, then you will have a very high success by pushing back the sclera to the retina with the macular buckle. If you have a tangential force breaking the fovea in a macular hole, then you have to counteract with an opposite force and close the hole with vitrectomy and ILM. And if the forces are combined, you will have to combine vitrectomy and buckle. I also published this proposal of treatment based on stage. So this is the same table enriched with the red lines that are the guidelines based on stage. So in the end, my advice is, if you have stage 1A or 2A, you should just observe, because the average visual acuity is very good, because the time taken to evolve is long, so there is no need to do anything, just observe. If you have a hole, well, especially a full thickness macular hole, then you should advise vitrectomy. We know that lamellar macular hole do not really need to have to be addressed aggressively with the vitrectomy, because sometimes visual acuity is good, so it depends on visual acuity, but a full thickness macular hole should be treated with vitrectomy and ILM flap. If you have a foveal detachment or full detachment, please learn how to do a buckle. You will be much happier by doing so. And if you are in stage, mixed stage 2B, 3B, 4B, I advise macular buckle first, and then treat the lamellar hole only if needed, because most of the time you don't need to. Only if you have a full thickness macular hole, then in these stages, you have to do a combined treatment that will guarantee to fix the retina, never have a relapse of detachment, and close the hole. So what about macular buckle? Macular buckle is a device made basically to shorten the axial length of the eye at the posterior pole. And years ago, they were made by sponges which were sutured posteriorly. It was a very difficult technique, dangerous. Forget about it, don't even try. So different models came out. None of them had a good fortune, because all of them required a difficult technique. And I presented the first model of modified macular buckle in 2009. And since then, I kept doing so. And I know that many colleagues are not doing, because there is no easy commercially available product, but I still believe is the best technique. This is how I modified the buckle in time, and this is how I make it in the OR. So top left, you see a titanium stent that I insert into a sponge, a 507 sponge, the one that you use for retinal detachment. Then I bend the titanium stent as an L. I cover with a sleeve also the lateral arm, and then I insert a light. So this is how I do it. I create a tunnel into the sponge, and then I insert into the sponge the titanium stent, and then I cover the which will be the lateral arm of the buckle with a silicone sleeve. And let me push forward. Yeah, so basically now you have the buckle, and then I insert the light. So very easy to make in your OR. How to insert the buckle? You can do it, as I said, without vitrectomy. You do a paracentesis first. I advise to use a twin light. So you place one in pars plana and one in the buckle. And so without knowing, I have used the chandelier technique to do episcleral surgery since 2009, but I haven't published that because I was focused on the macular, the buckle effect, and not on the chandelier. I just published later. So this is the view through the panoramic viewing system. You have to see where the buckle is, and then you can suture anteriorly very close to the insertion of the muscle. So with some training, it's very, very doable. And these are the suture. I place at least 2 to avoid any tilting and to fix the buckle in the right position. This was a combination with vitrectomy done with 3D, but the concept is the same. You see the pushing effect in the macula, and then you fix the buckle. The intraoperative OCT in this type of surgery is very useful to see the right location, especially if you have a macular hole, because you have to press against the hole, otherwise it will not work, and also to see how much you are pushing. This is another example. You can see the intraoperative OCT showing a huge macular detachment with a macular hole. So I released the tangential traction and also placed the buckle. And this is one further step of surgery. I was removing the cortex, the ILM, to remove the tangential traction, and then I placed the buckle to remove the perpendicular traction. That's it. I never use a silicone oil because silicone oil is very bad for these eyes. In this case, it was interesting because I could place the buckle just with the help of the intraoperative OCT without any endoillumination. As you can see here, I don't have any light inside the eye, and the intraoperative OCT is the only guidance to place the buckle correctly. So recently, I wanted to explore the efficiency of the Ajl Buckle because it is commercially available, so I don't have to use an off-label product. Unfortunately, it is just a single piece, and so I don't have the advantage of the titanium that allows me to tilt and modify the shape as I want, but it works well enough, and I'm exploring the results with this buckle, and I am designing an inserter and the marker in order to create an easier technique, and hopefully many colleagues will do it, because if I will make it easy, maybe it will be widespread. So let's see some examples. These are very scary eyes. I find very useful the wide field imaging, wide field retinography, and wide field OCT. And so this is a huge, it's a 23 millimeter scan showing a detachment with a macular hole. Counting finger was her vision. And as you know, these are eyes with very bad prognosis. If I ask you, I think if you can think about what could possibly be the final vision, your average surgery, it's vitrectomy with gas, vitrectomy with silicone oil, vitrectomy with ILM flap, vitrectomy with amniotic membrane to close the hole. And always I see average functional result, final functional result around 0.1, 0.2 maximum. But if you do this, if you place the buckle, if you close the hole, then you can reach this. If you don't have a huge atrophy in the macula, she can see 0.4 and she can read. Look, this is stage 3B, foveal detachment with the lamellar hole, and this is after buckle. He can see very well. Look at this eye. On the left, you see the detachment, and on the right, you see the final shape of the detachment result. Look at this eye. He had a very bad staphyloma in the papilla with the macula in the slope and a detachment, and this is the final result. Even this example, I place also microperimetry on the left because on top you can see the huge scotoma induced by the foveal detachment and the macular hole. Preoperative vision was 0.1 with search movement. And then 1 month later, she could see on the bottom, as you see the final result, 0.4. This is the patient that I operated in Retina, the live surgery that I have shown. Now it's 2 years after surgery, and now she can see 0.8 and reading. Look at the microperimetry change. So in conclusion, if you follow this classification and the guidelines, not the classification, sorry, the staging system and the guidelines to treatment, you can have very, very satisfying results, even with high myopic eyes. Choose the model of buckle that you prefer, but do so. And I'm sure I can guarantee your patient will be safe forever. You will be able to avoid silicone oil, because you know that with silicone oil, they all get glaucoma, and most of them get glaucoma and a very bad final vision. And you can reach very satisfying anatomical but also functional results. Thank you. Hello?
Thank you so much, Dr. Barbara,
Welcome.
for your presentation, and It is a very interesting presentation with very interesting successful cases. And we have plenty of questions and discussion regarding the topic, and we'll leave it to the end. Now, our next speaker is Dr. Hussein, and he's a consultant ophthalmologist, a professor of ophthalmology in University of Lahore General Hospital. And today he will speak about another huge topic, surgical retina, which is structural retinal detachment segmentation. Dr. Hussein, the floor is yours.
Thank you. Thank you, Dr. Noura. And nice to see you, Barbara and Dr. Rezendi. So after so much enlightening talks, my talk is just for the common people, common disease, and a lot of other things. So I am talking about the most common prevalent disease nowadays, is structural retinal detachment. So the thing here in this talk is exclusive is that I am talking only the one technique to treat the fractional retinal detachment, that is segmentation. I will share a few cases from mild fractional retinal detachment to the sphere. So this is my first case. A patient has a macular fractional retinal detachment, diabetic eye. So here you can see the preoperative or post-operative images. In this case, there is a mild fractional retinal detachment with this fibrovascular proliferation involving the macular area. I did the 23 gauge vitrectomy system. The 23 gauge vitrectomy system, you can segment the membranes lying anterior to the retina, far away from the retina with the cutter, and you can just completely segment it from the retina. Nowadays, it's more with the 25 and 27 gauge. Here I am using the vertical cutting scissor to segment it from the disc, and then the later fibrovascular proliferation you can easily chew with the side tip of the cutter. So this is the basic case that you can do with the cutter and few nicks of the vertical cutting scissor. So at the end you can see this patient was left with the BSS only, and at the post-op you can see there is a mild cavity hemorrhage, but later on it resolved. So I am sharing another case with a mild disease. This patient has mild vitreous hemorrhage and tractional band. The only thing to show this case is that the few bands and easily vitrectomy can do the miracles in these cases. So this is the only traction that I am just cutting with the cutter, and at the end the patient's macular tractional detachment resolves just with the few nicks of the cutter. So these are very basic cases where you can resolve the disease with a few minutes and with the very basic surgery. So here is my third case. This is pseudophakic eye of the patient with many membranes lying in the vitreous cavity. So I am doing the 360-degree membranectomy in the mid-vitreous cavity with the 23 gauge cutter. Obviously, I go 360 degree around the optic disc, and I leave the cauliflower-like membrane over here. Then with the cutter, you can easily chew it. But the game doesn't end over here. Here is a thick membrane lying over the retina, and I'm using the vertical cutting scissor to segment this membrane. These are just a technique of vertical cutting scissor using and doing the segment. So I'm using the vertical cutting scissor and making the small segments with the scissor. You can see the one segment, and this is the second one. And then these segments can easily be cut with the cutter, or you can easily pluck it with the end grasping forceps. So here the segments were made and then easily can be cut with the cutter. At the end of the surgery, you can see the few oozing vessel. There is a mild elevation of the retina that resolves at the end, and here is the post-operatively. You can see the retina is attached and there is no traction over the retina. This is another case with a relatively bad situation. This patient has a combined traction and rheumatogenic retinal detachment. He has uncontrolled diabetes, as usually in the third world countries we get. So here you can see all the fibrovascular proliferation is involving the macular area, dense hemorrhage, lot of membranes. So what I am doing here is just searching for any large breaks. If it is there, then I'm just doing the core vitrectomy in this case. After doing the core vitrectomy, main thing is that macula is totally detached with the rhegmatogenous element, and there are few breaks involving the posterior pole. So I'm just removing the membrane and cutting in the circular manner around the macula, and then I am approaching the main task. So here you can see the fibrous tissue is thickened and it has dragged the macula completely towards the disc. I'm just cutting the edges of these fibrous tissues. I'm going behind the membranes and cutting with the cutter. So if I get space behind the membrane with the cutter, you can easily dissect these membranes with the cutter and then cut these membranes. But it's not always easy to get a dissection behind the membrane and get the cutter behind it as I am getting over here. This is just a thick membrane and there are folds of the retina that are giving me the space to do this maneuver. And I'm just tucking the membrane with the cutter. So see how much attachment of this membrane are there. So this is basically a new idea technique that we are using. Just tuck the membrane, lift it a little bit if you have already rhegmatogenous component in this disease. So in this portion, I'm just lifting it, and then I will cut with the side cut of the cutter that without making any breaks. But you have to be very gentle in lifting these membranes with the end grasping or ILM force or whatever force you use, and then later on you can easily trim these membranes with the cutter. The basic idea here is you to have to avoid the break in these eyes at the posterior pole, but in this eye you have already rhegmatogenous element, so we were not afraid of making any breaks because we were using the tucking and cutting technique and then segment the fibrovascular tissue, and then with the cutter you can easily remove this fibrovascular proliferation from the retina. So this is now the nasal part. Basically, we are more concerned about the posterior pole as we have done with the posterior pole and this eye. So you can see we are moving the more membranes and trying not to leave any traction. So at the end, we are exchanging the air fluid exchange and leaving the eye under air. Laser is done at the end of the surgery. And at this, we finished. We prefer to leave the eyes under air in most of the scenarios, even we sometimes have a large break or small break at the posterior pole. This is another case. We have a patient with the pseudophakic eye. He has got rigid lens, and you can see the fibrovascular proliferation at the posterior pole, and there is a hemorrhage, fresh hemorrhage lying over the macular area. So as the principle, we are doing the core vitrectomy. I don't remove the vitreous completely in these cases. I just do the core vitrectomy and then do the segmentation and remove the fibrous tissue with the dissection. So here I am just cutting the membranes overlying the optic disc and over the macular area, and then back flushing the hemorrhage to see the membranes clearly. Here is my vertical cutting scissor and going to dissect and cut these fibrovascular proliferation with the vertical cutting scissor. The main thing that we do is that you just go with one prong under the membrane and just move it side by side to get a space between the membrane and the retina. Just make sure that you are not going through the retina or under the retina, so you can easily find the space between the fibrovascular tissue and the retina. So here I'm doing a little bit job with the cutter, and then I'm using the vertical cutting scissor. In this case, I just wanted to show you that how the lower prong of the vertical cutting scissor is visible under the fibrous tissue. That's the main concern, that you should find the better plane and you should know the dissection area. You can easily move side by side the lower prong and then cut these membranes. I feel this is the very safe technique, and you can avoid any iatrogenic break in this technique, and there is a far less pull of the retina if you compare with the bimanual technique, where there is a lot of pull and push over the retina. Here you can see I have made the segments over here, here, and here. So as much segment you make, as it is more comfortable surgery for the surgeon, and there are less chances of making the iatrogenic breaks. So I have already made 3-4 segments of fibrous tissue, and I'm going to make few more segments of this fibrous tissue. It's a little bit time consuming, but I think in this technique we have far less incidence of iatrogenic break in these cases, and then easily you can cut these segments with the cutter without making any iatrogenic breaks in these eyes with the tractional element and much more fibrous and vascular proliferation involving the posterior pole. So here I made 5-6 segments with the vertical cutting scissor. At the end, a few of them I chewed up. And then if you have a pegs not very much tightly, you can just easily pluck these one. But be careful, by plucking these one, you can just make an iatrogenic break. So this is not a wise technique, I think, much. So you better to dissect it with the vertical cutting scissor, make small segments, and then cut these segments, or just chew these segments with the cutter, or then it's like here you can see at the end we have done a lot of dissection and a lot of fibrovascular proliferation has been removed. But it's not always possible to remove all the traction. Sometimes you have bleeding vessels, sometimes you have a traction over there and few membranes, but it's 95% is far better than 100% worse. So I am just avoiding any iatrogenic break that I don't feel that it's good for the diabetic eye. So you here at the end you can see the post-op image, they have few membranes, but I am happy with the outcomes in these eyes with these outcomes. So I have few more cases. So in this case you can see the patient has a fibrovascular proliferation, now much more vascular component, and there is a hemorrhage, lot of membranes. Hemorrhage is fresh. We give the anti-VEGF before the surgery, but it's not always possible to have a good hemorrhagic control operatively. So in this case, you can see after the dissection of many membrane cutting in the vitreous cavity, there are still more membranes and fibrous tissue lying over the retina. So I'm doing a little bit job with the cutter, and here I'm using the vertical cutting scissor. With the vertical cutting scissor, I have very less chance to make the iatrogenic break, so I avoid to do the segmentation with the cutter, or even go behind the membrane with the cutter if I feel that there is a very little space between the fibrovascular proliferation and the retina. So with the vertical cutting scissor, you can easily find the space. It's a very good dissection, a tool for between fibrovascular proliferation and the retina. So here you can see I'm just keeping the eye light very close to the dissection area, because I was not fortunate to use the chandelier light. With the chandelier, you have much better view. So I'm just getting my view far better with the keeping the light closer to the dissection and using the high magnification for this procedure. So here is the membrane with the blood. So I'm not using the cutter to not make any break. So I'm using the vertical cutting scissor. So to cut these membranes, and then later with the cutter you can easily chew these membranes. So, but these membranes can be easily sometimes cut with the cutter, but if you have the option and you feel that you are more comfortable with the scissor, then I prefer to use the scissor. And here at the end we have few traction involving the nasal retina, but it's much less traction over the macular area. So I think I have done with my videos. I have few more, but I think my time is getting over. So at the end, take home message from my side is that in these tractional retinal detachment eyes, my concern is about if you have a no traction, no break, and no membrane, this surgery has excellent results, whatever it ends. But if you have no traction, no break, but few membranes, this is relatively a good
Hello, Dr.
surgical
Hussain, we
outcome.
can't hear you.
Sorry? Hello? Can you hear me?
Yes, go ahead and finish, Hussein.
Yes. Yes, and if you have no traction but you have break and few membranes, it's a relatively fair surgery with a relatively fair outcomes. But if you leave the traction and breaks and membranes over the retina, then I think the surgeon has done the failed traction or retinal detachment surgery. Just I tried to show the just one technique to deal with these eyes. There are a few more techniques for the delamination, bimanual delamination, but I am great fan of using these vertical cutting scissor in these eyes for segmentation. Everybody is free to use other techniques, but the main thing is that there shouldn't be any traction at the end of the surgery. Thank you so much for having me. If you have any question, I am here for the discussion. Thank you.
Thank you,
Thank you.
Hussein.
Thank you, Dr. Hussein. And your topic is as well very important for us because we have those cases very often. And so I would like to remind the attendees to write their question in the question box so we'll be able to attend their question. And at the end, so now let's start to discuss a few of the questions. We start with the panelists. So do you have a question to each other? Do you have anything that you would like each other to discuss and anything?
I do. I have a
from your
question for
side?
Barbara. Barbara,
Go ahead.
I have limited experience with the Ajl buckle. And your buckle seems to be much more gentle on the sclera posteriorly. So with AGL, you really have, you invert the concavity of the sclera, and your buckle, you kind of make it flatter, which I thought was really nice. Is that the case, or it's just it was misguided by the images you showed?
Actually, it is the case. Even with my buckle, if you run the different scans in different direction in the macula, you always have one which is very flat and one which is more concave. It depends on the shape. It's inevitable. But I tend to bend the buckle not exactly 90 degrees, a little less, because the final goal should be not to have the opposite shape, but as natural, as flat as possible. In this way, you obtain the maximum vision with no distortion. But the good thing with the Ajl is that we are building like a customized shape based in order to obtain the best final result. It's good, the one that I use, it's off-label, so it would be good to have a commercially available product. That's it. This is what I'm trying to reach.
Yeah, and the other thing that I saw as an advantage is because of the more, let's say, flatter structure of yours. With the AGL, I had a couple of cases where, because of the deep posterior staphyloma, the buckle was sliding. It was harder to place in position, and I think if you have like a flatter one, you have an easier
It's easier
time,
to obtain the final
pushing
location.
against the posterior stuff.
Yeah, and telling the truth, I don't think it's only the shape, but also the material, because if the material is too slippery, let's say, with the it moves more. I am trying also to work on materials, because if I have something with more friction, it will stay exactly where you place it. Otherwise,
Absolutely.
it moves in the orbit.
Right. I highly stimulate you to keep working on it, because
Thank you.
I think we have room for improvement.
It seems easy to me, but I know it is not considered easy, and the proof is that nobody is doing so. And I don't think I'm on the wrong side, because I have results all the time, and I keep receiving patients that were treated differently and have very bad results. So I think most of our colleagues consider a good result to end with the flat retina under silicone oil and the hole which is flat and closed, but it's not really closed. It's
Right.
just flat. I want to have vision. I want this patient to be happy and live their life without glaucoma and without any other relapse. So the usual story, I bet you agree, is that I receive a patient that has done vitrectomy with gas, and then they had a relapse of detachment, then vitrectomy with light silicone oil, then they remove the oil, redetachment, heavy silicone oil. The result is eye with glaucoma, no vision. That's it. This is the most common story. Instead, in this way, this can be saved with no relapse and good vision.
Right. People don't like hard stuff. You know, I work. You know, Nora knows about this. I'm specialized in hard stuff. You know, it's really hard for people to adapt stuff that is harder. So
I'm
your
facing
biggest challenge is to make it your technique
right
the easiest
easier.
possible. Then
Right,
people will say, "Oh my God, I have better results with this."
right.
Yeah. Congratulations.
Thank you.
Any question, Dr. Hussein? Dr. Barbara? We will hammer you with questions. I have so many questions for you.
Oh, Barbara, it's nice to see you. Your smiling face as always. Just want to encourage you. Keep it up. We are with you, and we are using your staging process. So, actually, in my part of world, we don't get these much cases of MTM. We are very few cases. You may remember I have one case where I eventually went for vitrectomy oil and I end up as you described. So with your more progress in this field, hopefully we will learn these buckles, and hopefully you get patent your buckle. And I'm great fan of buckling, you know, but we rarely get MTM cases. If I get in future, so I will obviously use your technique and will share results with you people. So keep it up. We are with you.
Thank
Hands
you
up.
so much.
Thank you. So there are a few questions from the audience, the attendees, regarding macular buckle. So first question from Dr. Amal. She asked, does macular buckle cause any double vision to patient post-op?
Yeah, it depends. I have about 6% of patients with double vision. 6% is what I counted because I take, of course, count of all my patients. They are more than 300 now, the one for whom I have data. So I think double vision you can have because the orbit is not always so big. You can have a big eye in a small orbit, and with the macular buckle, which is an extra foreign body in the orbit, you might have difficulties moving the eye. So I think that it is an acceptable complication compared to blindness. And even, let's say, if you wait at least 6 months, you can remove the buckle and still you will have the good effect because it will change the shape like with the peripheral buckle. It happens the same thing. If you remove it before 6 months, you risk to have a relapse of the pathology in the macula. So in case of double vision, I remove the buckle 6 months later and I try to work on freeing the muscles from possible scars. And, you know, usually it's taken care of. It's not the major problem. The other problem is extrusion because it is a foreign body. So again, even if with extrusion, maybe I cover and then I leave it for at least 6 months and then I remove it.
Another question regarding Ajl Buckle from Dr. Ahmed Al-Barqi. He is asking about any thoughts or experience with supracroidelecular buckling with fillers.
Yeah, I never wanted to do it, and so I cannot really comment. The reason why I didn't do it is because I was scared about entering with the filler in the suprachoroidal space, because in these eyes, as you know, sometimes I'm not even able to measure the choroid at OCT. It's like 20 microns, things like that. So I'm too scared of complication. plus I don't think it will last enough, because viscoelastic material will last for a certain period of time and then will disappear. But for these eyes, I've seen you need at least 6 months. So I prefer to have a permanent tool, that a medical device that maybe I can remove if I need to. I can tell that most of the patients that I operated still have buckles since like 15 years or 10 years, and I see them, and most of them are covered in the very back of the eye and don't realize they have it. So since I felt comfortable with this technique and I was scared with the other, I didn't use it.
Thank you. Any thought, Dr. Rezende?
Yeah, for suprachoroidal buckle, I have very good experience for peripheral breaks, and in high myopes, but for peripheral breaks,
That makes sense.
for myopic maculopathy, I think there's too many changes in the angle of the sclera with the thin choroid that it's really, really, really hard.
I mean, some of these eyes are.
Never mind the time that the viscoelastic stays, because I for instance, I no financial interest, I use Helium 5 and for the peripheral breaks, and 2 weeks later they're gone. But for the peripheral breaks, that's all you need is the time for the laser scar. So it's I love this technique, but only for peripheral stuff. The other question that I have for Barbara, actually, if I may, Noura,
Go ahead. Yes.
do you have any experience with sclera imbrication? Because I don't have much access to it. Like the few cases that I did with AJL, it took about an average of 9 months for the buckle to arrive here. So it was, it was really, really bad. So this is really not a good option for me. So I started doing sclera imbrication, and we do have a fairly good reduction of the axial length. So you may want to do a little arm to compare what you have, what you can get with sclera imbrication, so you can prove to the ones that are doing that your technique actually has decreases more the axial length or whatever benefits, additional
No, but
benefits.
it's not just about decreasing the axial length. Do you do it in when you have a retinal detachment, or even in schisis with attached retina?
Even in schisis with attached retina.
Ah,
Yeah,
so
depending on the forces,
the retina slides on
right.
the sclera?
Your classification is really, really good, because I rely on, depending on what the direction of the forces, and depending on the direction of the forces, I think this sclera imbrication, it's a nice alternative and much easier technique to do it.
Okay, I'm curious to see some of your OCT. I will learn something. Let's share.
Sure.
And it was one of the questions we received from the audience, Dr. Muhammad Al-Utaibi. He asked the same thing, any rule for scleral imbrication instead of macular buckling, because it's the same thing, it's access to this macular buckling. But sure, the very nice technique, make your own, right?
Exactly. I borrow basically the titanium stent from neurosurgeries, maxillofacial surgeries, just a titanium. And then I use the silicone material, which are the one that we already use for episcleral surgery. So nothing new. It's easy to use.
Do you actually have like a YouTube video of how to make it?
I have. I've made a course on the channel, which is called retinitaly.net. It's a whole course on MTM and also how to make the buckle. Thanks.
Another question. So I told you make audience very curious about scleral buckling, because it's totally new thing, and those patients usually are the hardest eyes to deal with. So one of the questions they ask me, Dr. Ala Atwan is asking, may I ask how long is the macular buckle? Please, is it too long enough for those high myopes eyes? So is there an estimation of the length of the macular buckle that you make?
So the one that I make, as far as the size, is very similar also to the AJL. So the lateral arm is 2 centimeter and the small arm is 1 centimeter. So the titanium stent is 3 centimeter long and I bend as an L, okay? And with this size, I can adjust to every eye. I have, I think I have a range of axial length up to 38 millimeters of axial length. So you can push down. So the distance from the limbus, the distance from the insertion of the muscle will be longer in long eyes. So, but you can adjust. And that's it.
So, Dr. Person, I was asking, what is the learning curve for placement of macular buckle? Any initial setbacks or complication? And how long were they managed?
Okay, so I think that the most difficult part is where to place the buckle. I think it is very easy to insert a buckle and place a suture because this is what you do already with episcleral surgery. You place, in the end, is placing 2 sutures in the sclera. That's it. The difficult part is to place it right in the exactly on the fovea, not too close to the optic nerve, not on the side, because if it's not there, it doesn't work. So that is why I'm focusing now on an easier way to mark the suture and know exactly where to place the suture. Anyhow, at the beginning, you need someone close to you, because you have to insert the buckle, and while you have the buckle in your hand, you look through the microscope through the panoramic viewing system, move the buckle and know and see the right location. So someone close to you have to wipe out all the blood and the fluids that are surrounding the orbit, the sclera, the episcleral area, and mark the place where to place the suture. This is the only difficult part. Mark well and suture well. That's it.
And what's the distance that you place your suture from the muscle insertion? How far back?
It's not standardized because every eye is different. So you have to insert the buckle, look through the microscope, search for the buckling effect exactly where you want. And that is the place. So I cannot give you the distance from the limbus because it's different from eye to eye. Some eyes have a staphyloma in the macula, some in the papilla, some have weird shape. So you have to check the moment. So I think that for a colleague that already does episcleral surgery, 3-4 cases maximum, and it's done. So now that I do as a routine this surgery, it takes to me half an hour. I place I open, I hook the 2 muscles, superior and lateral. I place the fiber optic in the sclera. I make the buckle, place the fiber optic in the buckle, insert the buckle, suture, close. That's it. So really.
Perfect. Yeah, I believe you need plenty of cases to be able to manage to do them in 30 minutes. Great work, Dr. Barbara. And I think those are the questions we received regarding scleral, regarding macular buckle. But I have one question. It's a case that I received with the high myopic, huge macular hole that has been operated twice. But you know, the only issue is the full macular, full thickness macular hole. But you know, there is no detachment. But what's the rule? Only the hole.
So, okay, so this is stage 1C with the big hole and the flat retina.
Yes.
And then in that case, there is no role for buckle at all. Because if you look at the table, I told you, the buckle serves only if you have to solve schisis or detachment.
Yes.
Otherwise, there's no use for buckle. You make it worse. If you have a flat retina and you push, you just enlarge the hole. It's a geometry that you need to have in your mindset. So in that case, you have to work with vitrectomy and plug the hole
Yes,
with whatever you want to use, amniotic membrane or other.
The Italians like amniotic membrane.
No, yeah, but I mean, if you have no, it's because she said it's been operated already. Of course, the first option is ILM. You can slide. I mean, you can use any other technique, but no buckle.
Yeah, definitely. There is no buckle. And I think the best option for her, because I got an experience with it, it's a neurosensory retinal grafts. And it's already very big hole. It is 1,700, very flat edge. And she has big holes, both eyes. And she's 0.1 and 0.2, the other eye, very poor vision. So I decided to book her for a neurosensory retinal graft. And
it's very big,
yeah.
so you might have as an option also the amniotic membrane, because you have to harvest a very large area of retina, and you might have different problems. So have a backup plan.
Exactly. So now we'll move to Dr. Rizandi, and I have a couple of questions. Thank you, Dr. Barbara. And for Dr. Rizandi, one of the question was, would you still, so what would you do if the retina is not stable during drainage? This is from Dr. Mahmoud Hassan. He's asking about the retinal stability during drainage. How would you handle choroidal effusion or choroidal hemorrhage?
I don't quite understand what's the retina instability, I guess.
I think maybe he means retinal detachment or adhesions.
What happens sometimes is that, and actually often, is that when you have choroidal detachment, you have, let's say, it's kind of like a buckle effect, and when you have too much indentation, you have, like redundancy of the retina, and sometimes some serous detachment of the retina, which is not necessarily a rhegmatogenous. And that's why, I emphasize that if you can, on the first surgery, just do the choroidal detachment drainage, and let the retina sit and see if there's really a rhegmatogenous component. But related to the technique itself, it doesn't really matter because you're on a suprachoroidal space. You're not in a vitreous cavity. So, the retina is not really an issue related to the technique itself. I think the biggest problem with the technique is for you to be able, to consistently do the tunnel to reach the suprachoroidal space, because there's many surgeons that they do a two-step wound, and they're used to do this. And for this particular technique is really dangerous if you go perpendicular, because you can, the length of your cannula, it won't reach the choroid, but the length of the trocar, the blade, can very well if you go perpendicular. So I think that the biggest challenge is for you to to be able to learn how to do a one plane at around 25 to 30 degrees, the plane of the blade in relation to the sclera, and go one thing. I used to call it the samurai technique. You have to do like an in and out, quick in and out, to be able to pierce through the sclera and stay in the suprachoroidal space.
Exactly. The other question I got is for you, Dr. Rizandi, as well. It's from Dr. Ahmed Al-Barqi. He's asking how to choose the location or site for trocar insertion in the transconjunctival.
That's an important topic that I haven't actually, I didn't mention during the talk. You have to do a B scan, ideally one day prior to the surgery, to determine which location, and ideally on a quadrant that has at least, you can measure the B scan at least 5 millimeters of height. That would be a very safe location to go. And then, when you saw, the video I did, the endoscopy video of the suprachoroidal space, you have to avoid the 3 and 9 clock meridians, because you don't want to damage the ciliary nerve. So, you can start your sclerotomy at, let's say, 3 and 9, but when you penetrate, you're not gonna, you can penetrate passing through the the horizontal midline, if you
Right.
will.
So Flavio, can I ask a question, Noura?
Yeah, go ahead, doctor. Yes.
I like very much the Trucker technique, which I actually use not just for choroidal, but to drain also retinal detachment, which are serous or without hole for any reason.
Right.
So the only difference, and I would like to confront with you, is that I prefer not to go blind and see inside. So I place a chandelier and the eye is in primary position in that case. And in that case, of course, the trocar is always tangential to the eye wall, but I'd like to see where of course, in the choroid, I don't see the trocar, I see it only in the retina detachment, but I see that I'm not going through. So that's the only difference. What do you think about that?
I think that it's because you're a very experienced surgeon that you're able to do this. Because most surgeons, where they have the difficulty is actually penetrating through the sclera on a choroidal detachment. You know, so you need a direct visualization for you to make sure that you're placing a good wound. If you're looking through the microscope, you're not really seeing your plane. You know,
No,
so
I
it's
just feel my hand going through.
right. It's just
But
because you're
I'm more
very
scared
experienced.
to see what I feel better to see inside the eye.
Right, but that's it. So, but if you have a chance of doing a B scan pre-op the day before, and you measure it, and it's 5 millimeters or greater, my experience, you know, the amount of experience that you have with the myopic stuff, I have with the choroidal detachment. You can go
I see.
blindly in that quadrant guided
Okay.
by a B scan because you won't be able to reach, unless you know, make sure that you don't go perpendicular like I
Yeah.
showed the
So if it is
non-drained.
less than 5, you just cut the sclerotomy
Yeah,
without.
well, again, then you know, with more experience, you can manage to go like, you know, more tangential, and you can still make it, but then it's trickier. And then for the drainage retinal detachment, then the choroid is attached to it. Then it's much easier to go through it, and then you can go. I also go direct visualization through the Ingenuity.
Perfect.
Nora,
The other
can I have one
question is,
question?
yeah, go ahead, Dr. Hussein. Yes.
So, Dr. Flavio, I just want to share a case I did 3 days ago. My resident was doing a phacoemulsification on Bruness and cataract, a patient of 18 diopter myo, and he got nucleus drop. I was operating on the side table. I shifted that patient to my retina table and planned for the removal of dropped nucleus. He put the IOLs, I sutured the wound, and then I put the trocars. When I went inside, I see there are large choroid detached. So at the same time, I thought to drain the choroid. It's just not acceptable for me what happened at that time. I just put the three trocars, and I was expecting that I will come out with the fourth trocar and I will drain the trocar. For this, I just removed the one trocar. As I am removing the first trocar, as it comes halfway away from the conjunctiva, there is a gush of blood, and it got drained in just you can say few seconds or less than a minute that it drained away.
Right.
So the thing here is, usually we drain the choroid with the oblique insertion of the trocar going in the suprachoroidal space, but here I went obliquely towards the optic disc, and direction was perpendicular, and when I lifted it up, it drained the whole choroid. That's something strange happened, and that is not ideally that should happen, but it was blessing for me that happened at that time. And
Right.
luckily, I got drained the blood at that time and managed the choroidal detachment, and obviously things got much better. What do you say about this? Because we know that if you are going for transconjunctival drainage, you have to go oblique from 7 to 8 millimeter. My trocar was just at 3.5 millimeter, and it was
Right.
perpendicular. And
Right.
I have this video. I was doing live surgery, and this was happening in the live surgery. So I have the very strange experience just 3 days ago on my live web streaming.
All right. Wow. Good. So what happens is like, so as you retracted, you were able to reach the suprachoroidal space and then it drained. The, the one of the reasons to go more posterior is for more complete drainage. Now, if you have fluid, your technique, it can actually work. So going more anterior, but the more, you know, many times there's a combination of serous and hemorrhagic. You know, sometimes it's like more viscous, and so the more posterior you go, the anatomy of, you know, having the infusion there, the more complete the drainage. Okay. But sometimes, you know, like one of the first slides that I showed, and it's actually on our paper, is that sometimes you go anterior like 2, 3, or 3.5, and you still in a suprachoroidal space. So you can actually reach the suprachoroidal space being at 3.5, and then when you are at 3.5, then you want to actually go
perpendicular.
like this. Yeah, right.
Perpendicular.
Yeah, not through the vitreous
You
cavity,
cannot
but just like that, exactly. So it's more dangerous, but you can achieve drainage this way.
But it was 99% unintentionally. I just wanted to bring my trocar out, and when I am bringing trocar out, it just gushed like a fountain. And just I stopped there and drained within seconds, everything gone.
Listen, good surgeons, they need luck as well.
Yes, I was lucky enough because a lot of people were watching at that time, and I didn't know what to do. I was planning just to go oblique and about 8 millimeter, and then I thought I will drain or not. It just drained.
So operating in live surgeries and physicians, these are very high risk for complications.
Yeah.
But you were very lucky, Dr. Hussein. I would like, because we are taking plenty of time for discussion, Dr. Barbara, she has to leave. That's why.
Very, very sorry.
I have to feed
sorry, we're losing you.
Please forgive me. I really have to go.
We wouldn't forgive you. We will see you soon.
Thanks. Thank you. Bye.
Thank you so much,
Bye.
Dr. Barbara.
Nora,
thank you for all the information.
I'm going to say goodbye as well.
Barbara.
Okay. Thank you.
Nora.
Thank you, Dr.
Thank you.
Bye, guys.
Thank you.
Take care.
Bye.
Thank you. Bye-bye. Dr. Hussein, I have a few questions for you.
Please.
It's the last questions here. Would it be more, Dr. Ahmed Al-Barqi again, would it be more beneficial to use the small gauge bevel tip probe rather than vertical Caesar alone, as it has less tractional force while segmenting the adherence membranes?
So what I got, yes, when you are using the vertical cutting Caesar, I believe there is much less traction on the retina. Rather, you are using bimanual with the horizontal cutting Caesar, because with the bimanual, you just have to lift it and you have to cut it. You are pulling the retina with your lift with the other hand, and obviously you need a chandelier light. With the vertical cutting Caesar, you are not lifting, you are just going between the two membrane space and cutting it. So I think there is a less pull and push in the vertical cutting Caesar, but it's a bit time consuming, and there is less incidence of iatrogenic break formation, interaction retinal detachment when you are working with the vertical cutting Caesar. But new surgeons nowadays, they want to finish these surgeries quickly. That's why they use chandelier and they do the bimanual surgeries. They just lift it and keep on cutting, lift it, keep on cutting. But how many times you are lifting the retina like a tent? If you pull it like 20 times in your surgery, then you think what you have done with the neurosensory tissue. So that's the only point of using vertical cutting Caesar. Obviously, bimanual is much a good technique, but you should be wise enough to use bimanual delamination technique.
Exactly. And you know, I was trained mainly with bimanual technique, but I had an access to vertical cutter, vertical Caesar, and really I enjoyed it. It made my life much more easier, because I have never used it, but recently I had an access to it, and it was a very safe, very secure, and very stable technique to use it. You know, I really enjoyed vertical Caesars.
It's really very safe technique. You will have a very less incidence of breaks, iatrogenic breaks. And second thing, that you will see like Picasso-like art. You will see the segments like cutting the membranes,
Yes.
and you are cutting. It looks very tidy surgery. It looks very neat surgery, and it's very controlled. With the bimanual delamination, yes, it's good. You can dissect more membranes more quickly, but it has its own. You can see harms and other things. So it depends on
Exactly.
surgeon's preference. I'm not a great fan of delamination, so I usually use the segmentation with the vertical cutting scissor. I can spend 10 minutes more for the patient rather than making him many breaks.
Exactly. Excellent. Thank you so much, Dr. Hussein. And I would like to inform everyone that within 1 to 2 weeks you will receive your CME certificate to the email that you register with. And thank you everyone for attending, and thank you for all the speakers for very informative, very rich discussion that we had tonight, and hopefully we'll be able to arrange further discussion regarding surgical retina. And I would like to invite you all to our Emirate Ophthalmic Society meeting that will be held in end of October, and it will be a virtual meeting, and it's a comprehensive ophthalmology as well. There is sessions about different subspecialty in ophthalmology. And thank you very much, and thank you Novartis for organizing and helping with the platform, and thank you Emirate Society meeting to help us to be able to do this webinar. Thank you, Dr. Hussein, for attending.
Thank you so
and
much,
I
Nora.
think
Thank you so much.
I think this is the end
See
of
you
our
soon.
webinar. Thank you so much, and good night for everyone.
Thank
Thank
you.
you. Bye bye.